By a little before midnight, every box for death was cleanly checked. No pulse on ultrasound, asystole on the 3-lead, and a flat capnography line. Minutes later, at cruising altitude, one box quietly unchecked itself. I am a fixed-wing critical care flight nurse with the Royal Flying Doctor Service, based out of Western Australia, more than a decade into this work. Our rule about endings is plain. When the heart shows true standstill, the chest gives no air, the pupils stay unreactive, and the end tidal carbon dioxide sits at nothing, the case is closed. The protocol has its steps. We follow them in order, because families and coroners and our own licenses depend on that order. The call came near the edge of the Pilbara on a late spring night. A remote clinic had stabilized a man in his early 60s after a collapse at a work camp. He was ventilated, sedated, and on a low vasopressor to nudge a thin blood pressure. The referring doctor worried about a right-sided strain, maybe a clot in the lung, maybe a failing right ventricle. The closest tertiary care was hours by road, and less than an hour by air on a twin turboprop. We launched with the usual kit: transport ventilator, portable ultrasound, defibrillator monitor with printer, infusion pumps, and a temperature probe in case we needed to chase a fever or protect a brain. The aircraft pressurizes, but not to sea level. We plan our cabin altitude like any other parameter. For bad lungs and fragile hearts, we keep the pressure as low as the airplane and weather allow. It spares the patient some gas expansion and some work of breathing, even on a ventilator. The pilot briefed us on smooth air above the dust layer and a steady ride. The cabin smelled of cleaning solvent and jet fuel, which for me is the smell of routine. On the tarmac, the handover was brisk and free of drama. The clinic team had placed an endotracheal tube at the first try and a radial arterial line that traced a damped but readable waveform. Their last arterial blood gas showed a carbon dioxide a little high and an oxygen in the 80s on a fraction near half, which is not pretty, but not unfamiliar in our line of work. The portable ultrasound at the clinic saw a big right ventricle and a small left. Suggestive, but not definitive. They had started heparin with a cautious hand. The man's skin was cool, but not mottled. His urine bag held a few clear milliliters. The story felt like the ones we move at least a few times a month. We transferred lines and monitors piece by piece onto our stretcher to avoid gaps in data. The witness I rely on most during flight is the monitor's event log. It timestamps every alarm, every rhythm change, every cuff measurement and print command. I set the monitor to record a rhythm strip every quarter hour and to print if the end tidal carbon dioxide dipped below a low threshold. The ventilator logged its own pressures and volumes. I scrolled to confirm the date and time were right. The pumps showed their rates and totals. I checked the ultrasound battery and left the probe in reach. My partner secured the head and triple-checked the straps because turbulence respects no one. We lifted into dark air that felt smoother than forecast. The cabin altitude climbed with us and settled in the mid-thousands, steady. The ventilator beeped once for a low exhaled volume and then returned to silence. A quick look at the circuit found a small leak at a swivel, which I reseated. The end tidal carbon dioxide trended slowly down, but remained above the low alarm. The arterial waveform did not please me. The dichrotic notch kept hiding, but the mean stayed barely adequate with the vasopressor. I adjusted the ventilator to a slightly longer exhalation to ease the right ventricle a little, and I raised the head of the stretcher by a few degrees. The oximeter steadied in the low 90s. The man remained deeply sedated, unresponsive to nail-bed pressure, with pupils mid-size and sluggish. Nothing about that was unusual given the dose and the disease. Halfway to the coast, the first anomaly appeared, small enough to ignore if not for experience. The capnography tracing narrowed, its rectangle turning into a sharp little mountain. and the numbers dropped by a few millimeters of mercury. In isolation, that can be an equipment quirk or a breath that doesn't sample well. I checked the sampling line for kinks and found none. The ventilator showed a slight rise in peak pressure, the plateau unchanged. The ultrasound, smeared with gel and steadied by my elbow against the stretcher frame, showed a right ventricle still big and a left still thin, bowing a little. The inferior vena cava looked full and not collapsing. Nothing screamed disaster. Everything whispered strain. The monitor's event log marked these beats without emotion. It marked a cuff pressure that read low and then read a little higher on the next cycle, which is why we carry an arterial line. It marked my print of a rhythm strip that showed sinus tachycardia with a right bundle-ish look, which fit the picture. It marked a small fluid bolus we pushed on the arterial waveform and the ventilator change I keyed in. It is a quiet witness, this printer. It doesn't argue, it just leaves paper. We reached cruising altitude, and the aircraft tucked into its long leg toward Perth. The pilot updated us on smooth air ahead and a runway slot that would be ready. I rechecked the blood gas with our cartridge device. It reported a pH not far from low normal, a carbon dioxide a touch high, and oxygen aligned with the oximeter. The lactate was raised, as expected, and the hemoglobin sat in a range that did not demand transfusion in the air. I printed the results and taped them to the clipboard that lives at the foot of the stretcher with the paperwork that follows every patient: signatures, times, doses. The second anomaly was less shy. The end tidal value fell again, across a handful of breaths, into the threshold that triggers the monitor to print. The paper skittered out with a tiny motor whine and an inked rectangle that shortened until the plateau almost touched the baseline. I checked the circuit for a disconnection and found none. The ventilator's exhaled volume agreed with the set volume. The peak pressure crept up another little bit. The arterial mean slid lower by a few points. I increased the vasopressor by a small amount and watched for response. The ultrasound, when I parked the probe in the subcostal window, showed the same strained picture and maybe a little less squeeze. My partner prepared a second line and drew a syringe of thrombolytic. We carry for cases that look like this, while I called the receiving intensive care registrar on the sat phone to flag the possibility. There was no drama in my voice. There was urgency in my hands. Then the rhythm shifted. The monitor alarmed for a run of wide beats. The strip came out spiky and mean, and then it went flat for a beat. The arterial waveform furrowed and then became a thin, straight line. The oximeter, belated as always in low flow states, fell behind. The capnography dropped toward nothing. We moved through the arrest protocol we drill. Call it. Start compressions if appropriate. Ventilator to manual. Drugs by weight. Ultrasound. To answer the one question we want answered. Any movement at all. The heart on the screen did not move. The lungs slid. The tube was still right. The pericardium was not full. We cycled through the medications and switched hands on compressions at the marks we know by feel, even when the printer refuses to feed us exact minutes. The end-tidal carbon dioxide flickered once and then settled at a thin line along the floor of the grid. The protocol for termination in flight is stricter than on the ground. We require persistent asystole, no reversible cause left untried, end-tidal carbon dioxide staying near nothing despite good compressions, and ultrasound confirming standstill across more than one view. We did not rush it. The event log recorded our checks. When the criteria were met and then met again, I looked at the time and I spoke the pronouncement for the tape, because that is what the procedure asks us to do. Even in a sky the patient will never know again. We secured the lines. We stopped the ventilator. We closed the man's eyes and covered his face. We informed the pilot and requested vectors to the nearest suitable runway. The cabin grew very quiet in the way it does after effort ends and respect begins. I printed the final rhythm strip for the file. It showed a straight line. I printed the end title tracing. It showed a straight line. I put the papers under the clipboard clip and reached to silence a non-urgent alarm that sometimes sticks after a termination. The monitor did not stay silent. The end title trace climbed by a breath's worth of height, held, and then climbed again. The carbon dioxide number, which had read nothing, began to count in small, steady steps. But a capnography that rose from nothing did not match a death we had just documented. The first rule of an audit in the air is to touch nothing until the instruments agree with your eyes. I watched the capnography trace climb from the floor by a breath's height, hold, then climb again. The monitor's event log printed on its own, the motor's small whine breaking the quiet. The paper showed a flat line, then a short plateau, then a taller one. The numbers at the side, which had read nothing, began to count in single steps. I restarted the ventilator and set a gentle rate with a long exhalation, then checked the sampling line for leaks. The connector seats were tight. No kink, no water trap full, no occlusion. I re-zeroed the arterial transducer to the level of the sternum and cycled the flush. The square wave test behaved as it should. On release, a narrow pulse appeared, low and shaky, but a pulse all the same. The waveform crept across the screen with a faint notch. The mean lived barely above the floor of what we accept. I scanned the man's chest with the ultrasound again, elbow wedged against the stretcher frame. The subcostal window was poor in the thin cabin light. The apical was better. I stared at the left ventricle until my own eyes watered and saw what might have been motion, then stilled to be sure. On the next sweep, there was no movement at all, only the valves nodding on the ventilator's push. I changed windows and looked again. If there was squeeze, it was slight enough to doubt. The ECG told a different story. It drew a flat baseline with wandering artifact that I did not like. I checked leads, swapped pads for fresh, rubbed the skin with gauze, and changed vectors to see if a low-amplitude rhythm was hiding. The strip printed the same. Isoelectric. The capnography did not care. It rose another notch and settled into a neat little rectangle, held for several breaths, then ticked up once more. The ventilator's exhaled volumes matched the set volumes within a small margin. The oxygen saturation, forever a lagging witness in low flow states, crept upward by a few digits. The event log stamped each of these changes without comment. I asked the pilot for the lowest safe cabin altitude and a shallow descent profile. The crew began a quiet change in pressurization and vertical speed that my inner ear registered before the instruments did. The cabin pressure change took some minutes, but as it came on, the capnography widened and rounded into a shape I recognized from living patients. The arterial waveform grew taller by a few millimeters of mercury. The mean climbed out of the fringe and into a range where organs begrudge you less. The thrombolytic we had drawn for a probable clot sat in its syringe on the bench. Our standing protocol allows its use in a witnessed arrest with a reasonable story of a massive pulmonary embolus, provided no major bleeding risk and consultation if reachable. The man had been on a cautious heparin infusion at the clinic. His story was right ventricle strain in a remote work camp, a sudden collapse, a high oxygen need, a swollen vena cava on ultrasound. The arrest had matched that story. Now the capnography and the arterial line suggested circulation had returned on its own, but fragile. I picked up the sat phone and made the call to the receiving team to declare what we were seeing and what we intended. Their answer will live in the formal notes. In the aircraft, the decision lived in the protocol and the clock. I gave the weight-based bolus and set the infusion. The evidence took form, beat by beat. First beat. The capnography trend, from nothing to a low plateau, then to a mid-teens plateau, then to a level that fit poor but real perfusion. The printed strip showed it in steps, each step stamped with a minute mark that we would later reconcile with the cockpit clock and the log of when we ceased compressions. Second beat, the arterial line. Waveform back, narrow and irregular at first, then improving in height if not in crispness. The mean rose into a safer band as the thrombolytic dripped in and the vasopressor rate inched upward. Third beat, the ECG remained stubbornly blank. I swapped cables, swapped monitors, and even briefly switched to a 2-lead view to chase any plausible deflection. The paper gave me nothing but straight ink and artifact. Fourth beat, the ultrasound. After the pressurization change and a few minutes of thrombolytic, the left ventricle showed short, hesitant squeezes. The right remained big. The septum fluttered. It was not pretty, but it was motion. Fifth beat, an arterial blood gas with our cartridge device, drawn carefully from the line after a flush, showed a carbon dioxide in a low normal band and an oxygen that matched the pulse oximeter. The lactate stayed high. The pH nudged upward from the prior draw. I taped that printout to the clipboard below the first. The mid-cabin got warmer by a degree as bodies and machines worked. The ventilator pressure alarms chirped once when the peak crept up, then fell quiet after I lengthened the exhalation further and trimmed the tidal volume modestly to reduce trapping. I set a higher oxygen fraction than before the arrest and watched the saturation settle into the 90s. The infusion pump clicked along, its display counting up volume delivered. The vasopressor syringe ran in a slow, steady thread. The man's pupils stayed mid-size and poorly reactive. His temperature remained cool despite blankets and the cabin's mild heat. Then came the second rupture, as clear as the first and harder to explain. The arterial line traced a pulse that matched the capnography breath for breath. The ultrasound on my third pass in the apical window showed consistent contraction, weak but real. The ventilator measured a slight rise in compliance. The oxygen saturation held. But the 3-lead still drew a straight line, and the printer still gave me a flat strip when I pressed the button. But pulses and carbon dioxide did not match a heart that the ECG still called absent. I entertained equipment error again, because pride and training both ask that you clear your own house first. I swapped the ECG cable with the spare. I moved the limb leads to the torso to improve signal. I cleaned gel from the ultrasound probe tip and stowed it to reduce electrical noise. I turned off and on the defibrillator monitor in a quick reboot that costs seconds and sometimes rescues a failed module. The paper I fed it after the reboot still came out blank of QRS. The artifact ran quieter. The baseline remained flat. I trusted the direct measures over the indirect. End-tidal carbon dioxide requires blood flow to carry gas from the tissues to the lungs. It cannot rise without circulation. An arterial line, when zeroed and tested, does not invent a pulse. Ultrasound, imperfect at the best of times in flight, showed motion. The ECG insisted on silence. The contradiction would live in my head long after we touched down, but the care could not wait for a tidy answer. We continued the thrombolytic infusion. I eased the vasopressor up another small step to bring the mean into a low target we accept in shock. I trimmed the ventilator further to protect the right ventricle. The pilot held the descent gentle and the cabin pressure as low as the airplane allowed. The event log rolled on, stamping each alarm and strip and press. I made short, plain entries in the paper chart. Capnography up from 0. Arterial waveform present. Ultrasound with weak squeeze. Thrombolytic started. Vasopressor adjusted. Cabin pressure reduced. A little before top of descent, the ECG showed its first confession. The baseline twitched, then produced a slow, wide, complex rhythm. irregular in spacing, but organized enough to name. The printer gave me a strip that matched the arterial pulse with only a small lag. The defibrillator module remained armed, but unused. The capnography held its plateau and even widened a hair. The oxygen saturation stayed in the low to mid-90s. The arterial mean held its modest line without further vasopressor changes. We landed in Perth under a clear night. The runway lights rushed past in white lines that I did not watch. I watched the monitor. The transfers from aircraft to ambulance and from ambulance to emergency bay are the places where lines get pulled and truths get lost. We moved methodically, one connection at a time, with the event log still printing at each threshold to leave a trail no one could dispute later. In the resuscitation bay, the hospital team took over with the practiced calm that comes from seeing what others think they never will. Their arterial line replaced ours. Their ventilator replaced ours. Their monitor showed the same slow rhythm, now with narrow complexes and a more regular spacing. Their blood gas, drawn from a fresh sample, confirmed a carbon dioxide in the low normal band and a pH that had improved. A bedside echocardiogram showed a dilated right ventricle with poor function and a left ventricle still thin. The thrombolytic infusion continued. A contrast scan was ordered with urgency, and the man went down the hall, riding a column of machines. I stood at the head of the bed, out of the way, with our clipboard and the roll of printed strips in my hands. The scan result, when it came, fit the story we had carried across the night sky. A large burden of clot in the pulmonary arteries, heavy at the split, with perfusion defects in both lungs. The report would later carry the words that match what we see every few months and never get used to. The right ventricle strain was severe. The decision was to continue lysis and consider catheter-directed therapy if the response stagnated. Back in the quiet of the corridor, I sat on a hard chair and went through the roll of paper with a pen, marking the moments that mattered. The time we called the arrest. The time the capnography rose from nothing. The time the arterial waveform returned. The time the ECG first showed a rhythm. The time the thrombolytic began. The time the cabin pressure changed. The sequence was clean on paper and messy in my head. The printer did not care. It only told what it saw. Before I signed the handover and cleared for rest, I wrote a short incident note separate from the clinical chart. We keep these when something breaks a rule. I wrote that we followed termination criteria to the line, that ultrasound confirmed standstill in more than one view, that end tidal carbon dioxide lay flat despite good compressions, that the pronouncement was documented. I wrote that minutes later, at cruising altitude, the capnography rose. An arterial pulse returned. Ultrasound showed weak motion, and ECG lagged behind them by a stretch that felt long in the cabin and looked long on the paper. I wrote that we treated the probable cause based on the story and the images and the labs we had. I wrote that the man arrived with a rhythm and a pressure we could maintain. The audit did not end there, but the flight did. The rest would be meetings, memos, and questions in rooms without windows. In the aircraft, in the air, it was instruments and hands. In the paperwork, it would become a case. The night of record became the 16th of November, 2024, when the hospital clerk stamped the admission and the scan report. The paper trail fixed the time points that had felt elastic in the air. In the intensive care unit, the man stayed sedated while the team measured what the body would allow. A bedside echocardiogram on the morning of the 17th showed a right ventricle still large and weak and a left ventricle that moved better than it had in the aircraft. The monitor in that bright room drew a slow, organized rhythm. The arterial line traced a pulse that no longer needed coaxing with each pressor step. A follow-up blood gas showed a carbon dioxide in a low normal band and a lactate that fell across the day. I watched these numbers settle into ranges that mean work ahead instead of a line on a form. The contrast scan that afternoon described heavy clot at the split of the pulmonary artery, with defects out to both sides. The report used plain phrases that matched the image in my head: high burden, right-sided strain, risk of further collapse. The lysis I had begun in the aircraft continued under the hospital's protocol. On the 19th, when the team measured the right heart again, the chamber was still big, but its wall moved a little more with each beat. An oxygen fraction that had started high trimmed downward by cautious steps. A ventilator that had pushed with long exhalations now allowed gentler settings. The infusion pumps stepped down a pressor thread that had held the mean pressure in a narrow band through the dark hours. On the 20th, the interventional team brought him to a suite where catheters changed the map of a chest. The note later recorded aspiration of clot and targeted thrombolysis. The room machines kept a clean record. The flow increased. The pressures across the lungs eased. Back in the unit, the arterial line traced a taller wave, and the capnography widened into a plateau that stayed steady breath after breath. The oxygen saturation sat in the mid-90s with less support than before. The echocardiogram that evening showed a septum less bowed and a right ventricle that no longer dwarfed its partner. On the 22nd, the team lightened the sedation in steps and watched the eyes. The pupils reacted, slow but present. A hand twitched to fingernail pressure. There was no following of commands yet, and no one expected it that soon. The chart carried phrases that hedge hope: purposeful appearing movement, cough intact, corneal reflexes present. The temperature rose toward normal. The ventilator settings eased again. On the 24th, the breathing tube came out. The first breaths without machine help were shallow but regular. The oxygen ran through nasal prongs instead of a circuit. The monitor on the wall kept its slow rhythm, and the blood pressure held without drugs. Across that day, the man drifted in and out of a light sleep and made small motions that matter to nurses more than they seem to. The next morning, he took sips of water. A speech therapist assessed the swallow. A physiotherapist sat him up with careful supports and counted steps in place. The room felt like recovery rather than rescue. On the 30th of November, he left the unit for a step-down ward. He wore oxygen by day and slept with a mask at night. He walked a short hall with a frame and a belt while a therapist stood at his side. The right ventricle still struggled on imaging, but the trend moved in the right direction. On the 12th of December, 2024, he went home with a plan for anticoagulation, clinic follow-up, and rehabilitation. The discharge summary did not mention the words that had started my paperwork stack. It recorded a cardiac arrest in transport with return of circulation and a diagnosis that fit the images and the labs. Our review began long before his discharge. On the 23rd of November, I sat in a windowless room with the base manager, the clinical lead, and 2 peers. The table held my chart, the hospital printouts, and the roll of event log paper from the monitor. We built a shared timeline from 4 clocks: the cockpit record, the monitor stamps, my handwritten entries, and the hospital arrival time. The clocks did not match to the second. They matched well enough for causality. We confirmed that termination criteria were met in flight: ultrasound, showing standstill in more than one view, and tidal carbon dioxide flat, despite good compressions. No reversible cause left untried at that moment. We confirmed that the pronouncement occurred after those criteria were met twice. We confirmed that minutes later, the capnography rose, an arterial waveform returned, and weak cardiac motion appeared on ultrasound, while the surface ECG remained silent, and that the ECG eventually declared itself only after cabin pressure adjustments and thrombolysis had started. The technical questions came next. We tested the defibrillator monitor on the bench and in the aircraft the following week. The ECG module passed checks. We repeated the scenario with a simulator that produces low-amplitude rhythms at odd axes, and we found ranges where the surface tracing is very small, while mechanical activity exists. We repeated pressure changes and watched how artifact shifts. We reviewed the route and the cabin altitude profile, and confirmed that a shallow descent and higher cabin pressure coincided with better signal-to-noise, and, probably, improved coronary and pulmonary perfusion as the right ventricle strain eased. The working explanation we wrote was conditional and plain. Auto-resuscitation after cessation of compressions has been described. Common threads include gas trapping and delayed venous return that catch up after the chest wall recoils. Severe pulmonary embolism adds its own obstruction that can change minute to minute under lysis. Cabin pressure and ventilation strategy can shift right ventricular loading. In that space, a transient return of circulation is plausible even after a period that met termination criteria. The discordant ECG may reflect very low voltage complexes below the detection threshold of the 3-lead configuration we were using at altitude, compounded by noise, cabin conditions, and the axis of activation in a strained right heart. Device failure remained possible, but less likely given later tests. We left the conclusion conditional because medicine punishes certainty when data are thin. The coroner's office received the incident note, the chart, and the event log roll. A liaison called for the packet on the 1st of December, and we sent it that day. A formal inquest was not opened because the outcome was survival, but the office reserved the right to review. Our service recorded the case as a near miss on protocol grounds, not because we erred in following it, but because the case showed how a clean algorithm can still meet a messy physiology. Policy moved at 2 speeds. On the 12th of December, the clinical lead issued a temporary practice notice for in-flight termination of resuscitation. It added an observation window after meeting criteria. Maintain monitoring for a defined short period with the ventilator on a manual low rate, minimize circuit leaks, and continue capnography and arterial line traces, if present, before signing a time of death. It advised re-zeroing the arterial transducer and repeating ultrasound views during that window. It also required, when cabin conditions allow, a small increase in cabin pressure before a final decision, to remove a confounder we can control without risking the crew. The permanent policy revision followed after the new year. On the 8th of January, 2025, our service adopted an updated termination checklist. It formalized the observation window, required a second clinician to verify standstill by ultrasound when available, and added a cross-check between end-tidal carbon dioxide and arterial waveform with explicit language. If either shows return of circulation, treat as living until proven otherwise, even if the surface ECG lags or is unreadable. The checklist also mandated printing and retaining all event log strips from the episode as part of the legal record, rather than allowing the roll to be summarized in writing. The case carried a personal cost that does not fit comfortably in a form. For weeks after the flight, I heard the small whine of the printer in quiet rooms that did not have one. I replayed the pauses between strips. I counted the breaths between a flat capnography and a rising step while stirring coffee at 3 in the morning. At the morbidity and mortality meeting in late January, I walked through my actions for colleagues who know the rules as well as I do. The questions were fair and plain. Why the pronouncement when I did? Why the thrombolytic when I did? Why the reliance on the capnography and the arterial line when the ECG insisted on nothing? The answers were the protocol as written and the physiology as understood in that moment. The room accepted them, but acceptance does not erase the feeling that the ground is less solid than it looked from the cabin. The man's follow-up visits put a human measure on the paperwork. In late February, He returned to clinic walking without a frame and breathing room air at rest. The right ventricle on echocardiogram remained moderately enlarged, but beat with better coordination. He tired by afternoon, and he forgot words when stressed, both likely from the illness and the arrest. He remained on anticoagulation. In late May, the ultrasound of his legs showed no new clot. He told the nurse he could climb stairs again. The chart recorded it as improved exertion tolerance. I read those notes on a quiet night in the base and filed them in the same folder as the event log roll. The unresolved piece remains the split between the early proofs of life and the late confession by the surface ECG. I can offer conditions: a 3-lead view that missed low-voltage complexes, a right-sided activation that favored leads. The monitor did not sample well, electromagnetic noise that drowned small signals in a metal tube, a module that behaved at the edge of its tolerance, a chest where the mechanical side found a path first. I can offer the literature on autoresuscitation and delayed return of circulation in obstructive arrest. I can offer the way cabin pressure shapes physiology in ways we think we know until a case tells us we do not. I cannot offer a single clean sentence that closes the file. The event log paper sits in our training room now, laminated, the key segments marked with a pen. New hires run a finger along the flat baseline and stop at the first step of the capnography. They look up when it rises, and the arterial waveform returns. They ask why the ECG stayed silent. I tell them what the instrument said and what we did with that information. I tell them the rule we broke and the rule we wrote afterward. I tell them to trust the devices that measure flow when the device that measures signal draws a blank. And I tell them that even when the protocol ends, the story may not.